we'll have no moderator band. So when we do our sheep heart dissection, we'll see the moderator band, and hopefully you won't cut it. Only one dissection group last night cut it. And in an ultrasound, it can be used to determine in the fetus which chamber you're looking at. If you're trying to get orientation, it's a little harder to see whether you have a thin right ventricle and a thick left ventricle with ultrasound or even in the fetal heart. So the last thing to mention up here is this irregular surface that I've hinted at. And these ridges of cardiac muscle in the ventricle are known as trabeculae carni. Trabeculae is another term for cord, and carni means meat. So we have the ridges and the auricles, which are pectinate muscle, and most of the entire surface of the ventricles are on those irregular cords known as trabeculae carni. They're a leftover of the embryonic development, but to me it's just an irregular surface that can lead to blood clot formation. The blood flow is weak or it's not regular, then blood cells and platelets can settle out and get trapped in those grooves and form blood clots. Now you may not have noticed as I drew the heart that I have a thinner wall for the right outer portion of the right ventricle and a thicker wall for the outer portion of the left ventricle. You'll see this and be able to feel it first, and then after you cut the where's my head? After you cut the sheep hearts, that the left ventricle wall is thicker, and this reveals the increased peripheral resistance of trying to push the blood through all the blood vessels of the body, compared to trying to push the blood through the blood vessels of the smaller region in the adult of the lungs. Okay? Now, let's review, before we get to the next set of valves, let's review a little bit of how the heart works. All right? So if we were going to talk about a sequence of blood flow from not one red blood cell at a time, but blood flowing into the heart. This is part of the lecture next week with cardiac cycle on Thursday and the following week. So the heart is at rest. Blood is flowing from high pressure, leaving the ventricles, to low pressure, where it returns to the atrium. So when the heart is at rest, blood enters both right and left atria at the same time. It continues to flow from high to lower pressure into the ventricles, all right? Same time. Then the two atria contract, squeezing a little bit more blood into the ventricles, and then the right and left ventricles both contract. So we have this kind of cycle, okay? Atria and then ventricles, and the heart relaxes. Atria, ventricles, and the heart relaxes. So lubbed up, lubbed up, lubbed up is the sound that we hear the valves closing, all right? So that's the complete cardiac cycle, which is both atria and both ventricles, and then the entire heart relaxing. But if we follow a single drop of blood, let me put this on blank. We follow a single drop of blood, it can only be in one place at one time, right? Or a single red blood cell. So if we follow a single red blood cell, and we'll take it from the body, take it from the brain. So it's going to come in the superior vena cava, and we can include inferior vena cava and coronary sinus to be complete. It's going to go into the right atrium. From there, it passes through the right atrioventricular valves, into the right ventricle. Okay? Now, if we're talking about the heart, it's going to be doing both at the same time, but one red blood cell is only going to be going in this sequence. So it's in the right ventricle now, and when the ventricle contracts, that pushes the AV valves closed, right? So now the AV valves are closed. As it continues to contract, the muscles are shortening, pressure goes up, and it pushes open this set of valves right here. So between the right ventricle and the pulmonary trunk, we have a set of valves known as the semilunar valve. So it's going to pass through the pulmonary semilunar valves. And there are no chordae tendineae attached to these because they are not under the same force of contraction, of blowing through as we see for the atrioventricular. Then it goes into the pulmonary trunk. And the pulmonary trunk divides into left and right pulmonary arteries. So it'll travel through one of those and go to the lung. Okay? The right of the left lung. Pick up oxygen. So all of this pathway, our red blood cell is not carrying very much oxygen. Then as it returns to the left side of the heart, it's going to be oxygenated. So it's going to return from the lung via the pulmonary vein, a right or a left pulmonary vein, to the left atrium, through the left atrioventricular valve, into the left ventricle, and then as the left ventricle contracts, it passes into the aorta by passing through the aortic semilunar valve. And into the aorta on its way to the body. Every part of the body except the alveoli of the lungs. So this is its pathway after it picks up oxygen. Okay? So if we're following just one blood cell, it can only be in one place at a time. So separating the pulmonary trunk from the right ventricle is this set of valves, known as the pulmonary semilunar valves. A lot of texts abbreviate that to this pulmonary valve, okay? However, if you mistakenly put aortic semilunar valve instead of pulmonary semilunar valve, I can give you half credit for semilunar. If you just put pulmonary valve, but it's not that, it's the aortic valve, I don't know that you know it's a semilunar valve, okay? So then the entire thing would be wrong. And then over here, we have the aortic semilunar valve, which is hidden behind the pulmonary trunk. So I'm just kind of intimating it there. And these are three little cusps that are attached to the side of the vessel. They open when the ventricle contracts, and they close when the ventricle relaxes. So where do you think the pressure is coming from that closes those valves? The pressure that closes the atrioventricular valves is the pressure of the blood as the ventricle contracts. The pressure of the blood as the ventricle contracts is what's pushing these valves open. So what's going to close them? The backflow. As the heart relaxes and the blood in the pulmonary trunk or the blood in the aorta flow back, those valves then fill with blood and relax. So the atrioventricular valves are hanging down into the ventricles like this. Okay? Blood's flowing from atria to ventricle, and as the ventricles contract, blood flows behind them and pushes them together. Chordae tendineae and papillary muscles keep them from blowing through. All right? Then the semilunar valves are angled in this direction. Pressure from the ventricles pushes those valves open, And as the ventricles relax, blood flows back towards the heart, fills up those little cusps, and closes them. Okay? So let's take a view of those. And then we'll finish up by looking at the blood supply to the heart.
And that's the same for the pulmonary?
Uh-huh.
With the whole.
Yeah, they're happening at the same time. So in this diagram, before we look at Netter's, you can see the two of the three semi-lunar valves for the pulmonary system. And if you look at your model, if you open up the ventricle, here's the pulmonary trunk coming right out of the anterior wall of the right ventricle. There's one of the three pulmonary valves, and up in here would be the other two. Okay? To see the aortic semilunar valves, you kind of have to pull back one of the chordae tendineae sets, and it's going to be up in there. Okay? So it's coming up out of the middle of the heart. So it's kind of hard to see that aortic semilunar valve. So a little bit of it there, but more prominent because it's more on the outside of the heart is the pulmonary semilunar valve. Okay, so let's see, I think we have a question to ask here. We haven't done it for yet, have we? Okay. So what is the, what direction to or from do the pulmonary veins carry blood? So pulmonary veins coming from the lungs or going to the lungs? Are the atria receiving or pumping chambers? That should help you with that. Okay, if you're not sure, I have arrows over on the board before I erase them. Okay? Alright, so if we look at these valves, you can see that 3 of the 4 valves have 3 leaflets. The tricuspid does, and the anterior pulmonary semilunar valve does, and so does the center of the heart, so does the aorta. So the only set of valves to have 2 leaflets are the left atrioventricular valve. Okay? All the others are going to have 3. And again, you can see here how the aorta is coming out in the center of the heart, whereas the pulmonary trunk is on the anterior surface. That will help you when you get oriented on the sheep heart during dissection today. All right, which of the following valves must resist the greatest amount of pressure from ventricular contractions? Remember I said body where it comes back from into the right atrium. So we have this intertwining circulatory system, this dual circulation. That's why the same volume has to be pumped by both ventricles, although under different pressure. If we had blood coming into the left atria and being pumped by the left ventricle, all right, but the left ventricle is diseased and it's weak, so it doesn't pump out as much as it comes in. What's coming in is being pumped from the right ventricle, right? Well, let's say that the right ventricle is pumping out 70 mils of blood per contraction, and the left ventricle is only pumping out 60. How much is going to be coming from the lungs? 70, because that's what the right ventricle is pumping out. But the left ventricle is only pumping out 60. So after a while, you're going to see that starting to back up because it's not leaving the ventricles. We're not getting as much going out as is coming in. It's going to back up into the left atria, and it's going to back up into the pulmonary veins, and then into the lungs to where we have those thin pulmonary capillaries. And what happens when pressure is too high in the capillaries compared to where the air is? Fluid's going to leak into those alveoli. So left-sided congestive heart failure leads to pulmonary edema first. Right-sided congestive heart failure, so if we have 70 mils coming from the left ventricle out to the body, then that same amount is coming back into the right ventricle. But if it doesn't, you can only pump out 60 to the lungs, then we're going to have more coming in than is going out. Does that make sense? So it's going to back up into the right atria and into the vena cavas and into the capillaries of your body, and that's going to result in systemic edema, where all the capillaries are in your body, okay? It's going to start probably first in the lower limbs because you have gravitational force moving it down there as well, okay? So that's why we need different pressures, different contractile forces, but the same volume. Now, next week we'll look at some of the pathologies that can occur. One of them is a switching of these two great vessels. The aorta, instead of coming from the left ventricle, comes from the right. And the pulmonary trunk, instead of coming from the right, comes from the left. In that case, we have completely separate circulatory systems. Let's take a look. If the pulmonary trunk is coming from the left ventricle, then the left ventricle is going to pump blood into the pulmonary trunk, which is going to go to the lungs, come back to the left atria, into the left ventricle, and get pumped to the lungs again, never getting to the body. The right ventricle that's pumping into the aorta is going to pump to the body, which is going to come back into the right atria, into the right ventricles, and pump to the body again. So we have two separate systems. Now, a fetus can develop that way because we have this foramen ovale. We have the mixture of blood. Usually, there's also an opening in the intraventricular septum, so it's mixing there as well, okay? That needs to be closed after birth. About 18 years ago, I had a student who had a high school age son who had gotten into behavioral problems in high school and gotten kicked out to a remedial high school for a while. He had kind of earned his way back in, and so part of that was community service, and she asked for his community service if he could come to class and talk about his heart condition when he was born. So like I said, normally they have a hole in the ventricle as well, ventricular septal defect. He was born without that, which meant that within minutes of birth, okay, and we're talking less than a minute after the cord was cut, he had to have surgery because he had no way of getting his tissue oxygenated. And he was, I think, the first baby in the Sacramento area to have that surgery done. The other babies had all died because he had no hole in his heart. So they couldn't wait to do the surgery. He had no interventricular septal defect, okay? So that's a switching of those great vessels occurs. All right, so that's the last of the questions. But let's take a look at now the blood supply. Here's a diagram, by the way, that illustrates the difference in thickness, the outer wall of the right ventricle versus the outer wall of the left. So when we do the sheep heart dissection today, and if you see images of it in the future, it is critical that you be able to identify right ventricle from left ventricle, because that's where everything else is gonna be identified from. So if you're looking at your sheep heart and you decide that this chamber is the right ventricle because of the thinner wall, then you'll know that this chamber above it is going to be the right atrium. And that makes this valve the right atrioventricular valve. It makes this valve the pulmonary semilunar valve, and this vessel the pulmonary trunk, all by knowing that this thin wall is the right ventricle. Or, we look at the left ventricle, that makes this the left ventricle, and this the left atrium, and this the aorta, and the same identification of the valves. So you can associate and identify these structures, but first of all, you have to be able to identify which chamber is which. You can use two things. You can look at the thinness of the wall, and then confirm that by the presence or absence of the moderator band, okay? All right, so let's finish up by looking at the blood supply to the heart, which is the very first branches that come off of the aorta. So this is another Netter's diagram. And we have two coronary arteries, and I want you to learn two branches from each. Okay, there are more, but we're going to learn 6 arteries. The right and the left coronary, and then 2 branches from each. That's what distributes oxygenated blood across the surface of the heart, and then down into the cardiac muscle, okay? On your models, you can see those vessels on the surface. So in actuality, there is no visceral pericardium here. It would take us about 4 hours to dissect that off of a human heart to be able to see the vessels. On the sheep heart, you won't see the vessels unless you scrape it off, but you'll be able to see pathways of adipose tissue, and that's where those vessels are found, all right? And then we have 3 cardiac veins that travel with those vessels to return the blood to the heart via the coronary sinus. So, I'm just going to draw the vessels, I'm not going to draw the heart. May I erase the board? You guys have all that? So, I have 2 sets of images here, one for anterior, one for posterior, but I only have one whiteboard. So I'm gonna, when I start to draw a vessel around to the back of the heart, I'm gonna start doing it in a dotted line. So that implies that we're kind of looking through the tissue of the heart itself, all right? So, the aorta has 4 parts to it. As we learn our vessels in a couple of weeks, we have the ascending, the arch, thoracic, and abdominal. So the very first branches that come off the aorta are almost immediate. And these are the right, which is long, coronary artery, and the left, which is short. So let's follow the right coronary artery first. It comes off of the aorta, travels in a groove between the right atrium and the right ventricle, and then curves around the back of the heart, okay? So that entire vessel is the right coronary artery. I'm going to put a bit of a gap between the vessels, so I'm going to come back and add the veins, the cardiac veins which travel with them, okay? This has 2 branches. Make sure you can look at the heart models and find them, all right? So the first branch is going to come down the right border of the heart and onto the right inferior border, along the ventricle. And so this is identified as the marginal artery. Then on the posterior aspect, the right coronary artery ends at this groove between the left ventricle and the right ventricle. When you turn the heart around, you'll see it make a right angle bend. So here, this is still coronary artery. And then that right angle bend passes between left ventricle and right ventricle and is known as the posterior interventricular artery. So this is all right coronary, and then that is the posterior interventricular. The right coronary artery with two branches, marginal, posterior interventricular. Okay, the right coronary artery kind of goes around the curve or the waist of the heart. So we're seeing left atrium here, right atrium here, pulmonary vein, and inferior vena cava and superior vena cava. So let's go back to the anterior view now. And we have a very short left coronary artery. And in your models, you can hardly see it because most of it is traveling behind the pulmonary trunk. All right, so you're only going to see about 1/4 of an inch, 1/2 centimeter there, because most of it is behind the pulmonary trunk, and so the model makers didn't show it. So just a short piece right there. And then it divides almost immediately into the two vessels we're going to learn for it. So here we have the left coronary. Not cardiac, but coronary. The veins will be cardiac. And as I said, it gives a branch off almost immediately that's going to travel between the left ventricle and the right ventricle on the front of the heart. So that makes it the anterior interventricular artery. Now something that's a little unusual, given the importance of the organ of the heart to our body, and that is the lack of anastomosis. I don't know if you've heard the term anastomosis before, but in the shoulder, the hip, and the knee, we have lots of branches that are coming off of the major arteries before and after the joint, and they join. So if there's a large clot in the major axillary artery, blood will back up into some of those branches and join and come back into the brachial artery here by going through some of those branches that supply the shoulder joint, and not just lose your arm, your upper limb. Where you would think there should be an anastomosis with an organ as important as the heart, there is not. So if there's a clot here blocking the anterior interventricular artery, blood's not going to be able to come to this region of the body by coming down the posterior interventricular and getting onto the anterior surface of the heart. They don't make those connections. All right. So increasing your exercise, making the heart work harder, is one of the best ways to get more and more and more blood vessels to form. After a heart attack, or heart damage, when a person may not have that time, they actually can trigger the heart to make additional vessels by burning holes with lasers and kind of creating channels that encourage blood vessels to form. Anterior interventricular artery is not a name, it's an anatomical name, but it's not a name that you would see in the medical field. We've seen angiograms. This vessel is actually known as the left anterior descending artery, or LAD. If you've seen labeled x-rays or angiograms or something like that of the heart, you're not going to see anterior interventricular. So you don't have to know that other name, but I'm just saying different terms are often used in the medical field. Okay? Then the other branch actually does what the right coronary does. It forms the other side of the waistband belt that goes between the atria and the ventricle. So it's going to wrap around the left side of the heart. And come to the back of the heart. Now there's also a marginal artery given off there, but you don't have to know it. So there's other names that we have life, and so this one is called the circumflex. 'Cause that's what it does, it circumscribes a circle around the heart. And that's because the left coronary artery is so short. So that really has the same pathway on the left side that our right coronary has on the right side. So if we turn this around, look at the back, here comes the circumflex. Now on some of the models, there's a painted area. It shows the circumflex joining the right coronary artery, and they don't, okay? There's a definite gap in the provision of blood on that side of the heart. So, a right coronary artery, a left coronary artery between the atria and ventricles, with giving branches the marginal artery and the posterior interventricular coming off the right coronary artery, and the left coronary artery forming the anterior interventricular and circumflex. Okay? Then we have three veins that travel with blood flowing in the opposite direction with these arteries. So let's do the great cardiac vein first. So the great cardiac vein, well, let's switch it so I have the names of the veins on there actually. The great cardiac vein is found with two arteries. It's found with the anterior circumflex, and then it's found with the, anterior interventricular, and then it's found with the circumflex. Okay? Some texts call it the anterior interventricular, but that only works here on the front. It's not interventricular when we find it up here. So I prefer great cardiac, which works in both locations. So after the heart is used up much of the oxygen in the muscle tissues, the small venules return to the surface of the heart and end up back in the right atrium. So we have the great cardiac vein, and then it's going to travel with the circumflex. And when it gets to the middle of the back of the heart, it actually dilates and forms the coronary sinus. Okay? So the coronary sinus that we see in the next image is actually a dilation of the great cardiac vein. And the coronary sinus is the third vessel that empties into the right atrium. So, and just put letters for these. So this would be the great cardiac vein. And it's forming coronary sinus. All of this would be great cardiac vein. Then, come around the back here, we have the middle cardiac vein, and we only see that with the posterior interventricular artery. Is that a dotted line? And that's going to empty into the coronary sinus as well. And that is the middle cardiac vein. Let me put great cardiac vein over here with the circumflex as well. Okay? Then we have one more, and that's the small cardiac. The small cardiac actually helps you find the marginal artery because we have a few veins on the front of the heart. These are called anterior cardiac veins. Your model only shows one, but they don't go into the coronary sinus, they go directly into the right atrium, all right? So these are the anterior, but the small travels with the marginal artery makes a right angle bend to travel with the right coronary. So here we have our small cardiac vein. And then it makes this right angle bend. And we find it on the back, where it's going to empty into the coronary sinus as well. So make this a C. The left coronary artery doesn't have any of the cardiac veins traveling with it. But the others must have. The right cardiac vein travels with the anterior interventricular and then the circumflex to become the coronary sinus. The middle cardiac vein travels with the posterior interventricular to drain into the coronary sinus just before it enters the right atrium. And then the small cardiac vein travels with the marginal artery. You can see it making that right angle bend on your models. And then travels around to the back of the heart with the right coronary artery to empty into the coronary sinus as well. So we'll be able to see the coronary sinus in the sheep-heart dissection, but not the other vessels. All right, so we're done with lecture. Go ahead and take a break if you wish, and spend some time with the models while I get the sheet charts ready. In your lab packets are directions on how to do that. And then Jeff helped me set this up last night, so instead of you waiting while I got to your table to help show you how to dissect, I can show all of you